go ahead and get started, and others who come in will come in. One of the important things that I wanted to talk about today is encrypting emails when you have sensitive information in order to keep up with HIPAA regulations. As you all know, the Privacy Act, it changes weekly. But when we send health information via email, it has to be encrypted. Now, we here have looked at many, many different systems, but they're all very expensive, which is why you haven't heard me talking about it. But I found one that is free of charge. You can pay $44 a year if you wish to have the expanded version, but for our purposes, I think that the free one works out just fine. It's called Proton Mail, so please take note. And you're going to look up how to create a free Proton Mail account, how to get started. Go to Proton Mail sign up page, and it walks you right through the process. If I can do it, you can do it. And this way, let's see, you can have, here's my page. Once you have signed up, these are all of the things that you can do, your dashboard. I'm Karen, IRNPA at Proton Mail, which I will use when I'm sending or, sensitive information. It's just a lovely thing, secure access. The center is in Switzerland, land of privacy. It's simply all encrypted, and you can have it free of charge. So I would highly recommend that you take a look at this and see about signing up yourself. You can have this web address, or excuse me, this email address in addition to the one that you are already using. And they can all go into the same place. If you have questions about that, you can check with Scott and he'll tell you how to do it. But I'm sold. This is absolutely the best one that I have ever seen, and it's free of charge, which blows me away. Anyway, questions? Somebody's talking, but I can't hear you.
Mary, you need to mute yourself.
I thought I was.
No.
Somebody's talking and in a black box, and I can't hear you. TJ, is that you?
It's Yvonne.
Oh, hey, Yvonne.
Hi.
Hi. Did you have a question?
No, I was just joining on. I'm going to silence myself because I'm driving home.
Okay. This is about encrypting sensitive medical information via email.
Okay.
And this is the only one that seems to be very legally reputable and free of charge. So I wanted to share it with everybody. Proton Mail. Please look it up, and before you send out any sensitive information, send it through Proton Mail. It's all encrypted and so HIPAA compliant, okay?
Excellent, excellent. Is there anything on the other, for the recipient, anything that they have to do or know?
It depends, but you can learn more if you go to their site.
Okay. Okay, great. Thank you.
You're welcome. All right, now I'm going to stop sharing here, and we will turn it over. I'd like to introduce you guys, for those who don't know her. This is Charlene Barron, RNPA, down on the west coast of Florida. And she and her sister have a group practice there, and they are doing very, very well. Charlene, you and Mary came to class in 15?
Yes.
Yeah. So they've been at it for quite a few years and they have a great deal of experience. Charlene has had some health issues and has been very successful in working with her providers and her own knowledge base to resolve them. So one of the things that, one of the therapies that Charlene has become expert in is called low-dose Naltrexone. How many of you have heard of that? Okay, good. Well, that's what today is all about. So this is Charlene. Charlene, I hand it over. There you go.
Thank you, Karen. Hello, everyone. Great to be here. I'm excited to present on this topic. It's definitely something I'm extremely passionate about. My sister, Mary Barron, is on the call. She can probably attest to my obsession with the topic. So I will just begin by opening my PowerPoint presentation here. If I can figure that out. Okay. Just bear with me a moment. All right. Let me just share screen maybe. Okay, can everyone see a bunch of people's faces?
Yes, there they go. Yep.
Okay, so I do improv actually, and those are that's my improv group. So improv has also very much helped me. So maybe that's also another day's topic. Yes, as Karen said, we are in Bonita Springs, Estero, Naples, Fort Myers area. Down here in Florida, and we this topic of low-dose naltrexone has become very I'm very passionate about it, mainly because I've used it in my own life, and I've just seen through my own use, and then through that, just interacting with other people and seeing other people take it, and just seeing how much it can help a population of individuals. There's traditionally not been a lot of answers. So as we go through the slides, it'll become more obvious. I'm sorry, Mary, you're not muted. Thank you. As we go through the slides, oops, Mary, you're not muted. I'm wondering what's happening there, Mary. Thank you. Sorry about that. So as we go through the slides, it'll become more obvious kind of what this medication is and the different ways we can think about using it. Everyone on the call has heard of naloxone, or everyone's heard of naltrexone. Is that accurate?
Ask about Narcan.
Yeah, so naloxone is Narcan. So it's an opiate, antagonist, and we know that works pretty quickly, which we're grateful for when we need it. Low-dose naltrexone is a medication that works a bit slower, but it still has similar mechanisms of action. So we'll get into that in just a moment. So let me just share here. There are several books, there are several resources. I'm going to go through those as we talk. If anyone has a question in the middle of the presentation, just let me know. I'll write it down if I can't answer it right away. Sometimes I think questions are best answered as they're coming up. If it's something I don't know, which is completely possible, I'll get back to you. So this is one book I like. It's called The Power of Honest Medicine. This is written by Julia Shopik. She's a health advocate and an advocate of low-dose naltrexone. And she has her own personal story, especially with the health of her husband. So some of today's presentation is taken from information from that book. This book, The Power of Low-Dose Naltrexone Therapy, also used today by Elaine Moore and Samantha Wilkinson. Elaine Moore has extensive knowledge in immunohematology and toxicology, and Samantha Wilkinson is a patient advocate for multiple sclerosis and low-dose naltrexone. This book is extremely scientific. It is very, if you like biology and, chemical processes and immune system, really explained in depthly, this is a good book. Part of the issue with the information on low-dose naltrexone is things are in terms of information that's coming out, it's developing all of the time. So you might read something from 2009, and then you're going to read something from 2019, and not that the information is different, but it's probably just possibly a little more expanded upon. So that was something that I faced when creating this this presentation was I definitely got a snapshot into the trajectory of how this medication has been used and the information that they've known or not known over the years. Okay, so let's see, I'm going to move this little guy. There we go. Bear with me. Okay. Are you able to see me moving this little thing around?
I don't see any little thing moving. I'm waiting for the next slide.
Can you see the next slide now? Why this topic?
It's right there. You help her.
Yeah, we can see your arrow.
You can see this quote, in my opinion.
Yes.
Okay, thank you. So this is a quote by Julia Shopik, the lady that I first discussed. She says, in my opinion, LDN is one of the most important medical discoveries of the 20th century. Hundreds of doctors who prescribe it and thousands of patients who use it agree. LDN, which works for so many conditions, is also the cheapest and most versatile of treatments I have encountered. That's true. It's very inexpensive. That's why there's not a lot of, that's the theory that as to why there's not a lot of research being done in terms of like pharmaceutical companies, because it's kind of past that point of, you know, possibly being able to make big money on it. Naltrexone is in some other medications such as Contrave. It's combined in a higher dose with Wellbutrin as a weight loss medication. So you'll see in other forms where they're combining it or using it for addiction and things like that. But this low dose naltrexone form has to be compounded, or people are kind of making their own concoctions at home, which I'm not as much in favor of, but you know, people have to do what kind of they're empowering themselves. So, and I apologize, I'm just going to also be looking down at my notes. I have 12 pages of notes here, so see what we can get through today. So why did I pick this topic? I've already discussed that I have a personal experience with it. But kind of in the healthcare arena that we are in now, obviously everyone's very acutely aware of this opioid epidemic. People, you know, a lot of individuals are experiencing pain. A lot of individuals are on these opioids, you know, for a long time, and it just kind of seems to snowball, and there's people have a hard time getting off of them, and then there's, you know, the rebound pain, and so people are really searching for another way. We're seeing obviously a lot more autoimmune disease, neurological disorders, chronic pain, and obviously we know how costly the medical system is becoming, specifically in chronic illness and chronic disease. And I think for all of us, we probably know and have seen how, you know, in a lot of arenas, the healthcare system is failing to address a lot of illnesses that could use preventative care. And I'm not sure that, you know, it's doing as great a job at that as it could. Okay, so what is naltrexone? So naltrexone, as I said, is an opiate antagonist developed in the 1970s. So they needed to develop a medication because there was a heroin addiction occurring. So they developed this medication, and then it was approved in the mid 1980s for drug addiction. And then it also became approved for alcohol addiction. And the dosage that you're looking at for an addiction is more around a 50 milligram dose. And it's, you know, I've seen kind of 50 to 300 milligrams. And that's going to have a pretty large opiate covering effect, opiate receptor covering effect. And that's not what we're looking for in the low dose naltrexone, which is a much smaller dose. And let me just read my notes here to see if there's anything else. Okay, let's see. So low dose naltrexone has been used off patent for many years, meaning there's no branded naltrexone. Sorry. So naltrexone itself, just naltrexone, has been used off patent for many years, meaning there is no branded naltrexone that is manufactured and marketed drug company. So that's kind of what I was discussing in regards to drug companies not wanting to invest in research, because we're kind of past that point with just the naltrexone medication. Low dose naltrexone in the smaller dosages, and we're talking anywhere from like ultra low dose of 0.002 milligrams I've seen to 5-6 milligrams, 4.5 milligrams. That's also been used off. That's also been used for many, many years for things that are different than addiction. So there is a long history with this medication, both in the addiction world and in the world that I'll be speaking about, which is more the inflammatory fibromyalgia, chronic fatigue. People use it in cancer, MS. So it's also been used in that way and more anecdotally, but there is some research which I will discuss. I'm just going to pause and see if anyone has any questions.
Well, Charlene, I just wanted to throw a thing in. This is Karen. I used to work in recovery room now, it's called something else, post anesthesia, but Narcan is frequently used in that setting to help people wake up.
Mm-hmm.
So anybody has worked in that area will be very familiar with Narcan.
Right. And again, that's naloxone, that's instant. So we're seeing, that mechanism of action occur in real time. So we see how powerful an opiate antagonist can be. It's quite, when you kind of think about the fact that they created that, that's pretty remarkable, I think. And so when people talk about low dose naltrexone, usually they're talking about milligrams of 25 milligrams or less, and often it's actually 10 milligrams or less. There's a lot of different schools of thought out there, where different physicians like to use this medication differently in the low dose form, but you'll kind of see that, that range. So I'm just gonna, okay. So when used in low dose, it's now widely understood to act as an immunomodulator, and multiple phase 1 and phase 2 trials have shown efficacy. And that's from the LDN Research Trust, and that is something I will discuss in a little later when I talk about resources. Okay. Oops. So we have this slide, wide low dose naltrexone here. So, one thing that was very curious to me is how did this medication, because it took me a full year to decide to do it, even though through my reading and my research, people had very little side effects, but I'm just not really a big medication in person. Any kind of synthesized medication that I'm going to put in my body, I usually take a while to decide on. It's some emergency situation. It's just me. But so through just my study and my reading everything, the story emerged of how this occurred. And there's 3 main doctors that people usually talk about, a Dr. Zagan, McLaughlin, and Bernard Behari. Usually you'll more hear Dr. Behari's story. So first we have Dr. Zagan and McLaughlin at Hershey Medical Center in Pennsylvania discovered that naltrexone affects cell growth in different ways, depending on whether high or low doses are used. they discovered naltrexone increased production of two naturally occurring endorphins, opioid compounds, when used at a fraction of the dose. So again, that rebound effect, that's what you'll hear when when you hear about low-dose naltrexone. A lot of times you'll hear the phrase rebound effect. So the opiate receptors are covered, usually around the hours of like 4 a.m. or something. I'll talk about that in a moment. And the body is like, oh my God, it's like, wow, these receptors are covered. We need, let's produce some more endorphins. Produces more endorphins. And then the theory that has existed for a long time is that rebound effect of those additional endorphins in the body has an anti-inflammatory downstream effect, a downstream cascade of anti-inflammatory processes. And so the other doctor, Dr. Bernard Behari, in the mid-1980s, he was a doctor. Let me just go to my notes here a moment. I know he was treating addiction, and he was actually a Harvard-educated neurologist, and he was director of the Division of Alcoholism and Drug Dependency at the State University of New York Health Service in Brooklyn. And so he was using naltrexone, just regular naltrexone, for addiction. And so kind of concurrently, he was having a lot of HIV patients. And I believe actually at that time, I don't believe that was the diagnosis. I don't think that they had labeled it as such yet. But he was seeing that there was a reduction in incidence of Kaposi sarcoma in the patients that were using naltrexone. And so he began using low-dose naltrexone. From my reading, it's stated that he discovered also the research of Zagat and McLaughlin at the Hershey's Medical Center. Sorry, my dog is here. I'm just gonna put her out of the way. Okay. And kind of incorporate that into what he was already seeing. And so his findings showed improvement in immune function in HIV patients. He did do a clinical trial. However, from what I can tell, it seems like some of the, because he was doing a lot of these things on his own, because he was just so fascinated by what he was seeing in low-dose naltrexone and the immune system, and then he expanded into cancer. When people went back and kind of looked at his records, I don't think the information held up as much as they would have liked to be able to publish things. There is published literature, but that's just what I can tell. I'd have to dig into that a little bit more. Whoops, do we have a question? Let's see. Okay, I'm not sure what that means. It's my sister. Mary, did you have a question? I can see my niece. Okay, so sorry about that. All right. So he did present his information at a conference on AIDS in Paris, France in June 1986. All right. So I'll just share a little bit about my story. I don't, we don't have a ton of time here, but about 17 years ago, I was diagnosed with fibromyalgia. I believe that's how long ago it was. I'm not sure. But up to that point, I had a few illnesses as a child. I had a lot of strep infections. I had a lot of ear infections. I had for 2 full years of my life, I had urinary tract infection. A lot of antibiotics, and just also as a child kind of demonstrated some anxiety or obsessive type traits. And I now kind of in my own diagnosing of myself believe I probably had a PANS or a PANDAS presentation, which is a pediatric autoimmune inflammation of the nervous system due to strep infection, which I did have a lot of those because it came on very suddenly. And so I think that that's important, and you'll see why in a little bit. So at the age of 17, I also got, a few years earlier, I had Epstein-Barr virus, mono, was so ill to the point I couldn't even get out of bed. And no one knew. So I just received months and months of antibiotics, actually. And so then I just became very fatigued. I kind of had body aches all over. My glands were swollen. This went on and on for years. And at that time, there were so many different theories on what caused fibromyalgia, kind of bouncing around from person to person, even functional medicine providers, noting that, you know, I'd have inflammatory markers such as a high reactive CRP. And so I even found an old MRI of mine from a brain scan I had due to headaches. And it was interesting because I saw that it said probable inflammatory process in the brain. And, you know, that kind of actually gave me a lot of pause, because kind of when you put the whole picture together, it's your own story, it's quite interesting. So fast forward, let's see, I did a lot of things on my own, getting a lot better through the years, but kind of like never really feeling like, you know, just never feeling like I really had that zhuzh, that, you know, that I was always exhausted, honestly, and in a lot of pain. And I also was diagnosed with pseudotumor cerebri, which is increased intracranial pressure, and had a headache condition. So these are all, you know, kind of inflammatory. They don't know what causes that illness, but I have my own theories on it. And so I do believe a lot of it is probably inflammatory. So then I began to take low-dose naltrexone, I believe about 3 years ago, in addition to other things that I was kind of doing at the same time. And it was like within a week, it was as if this fog or this like sludge that I felt in my whole nervous system was gone. And to feel that way for 17 years and then to suddenly not feel that way is like, I will probably never get over my gratitude for that, for discovering that, for taking, you know, another nurse advocate actually is the person that first kind of convinced me to try this medication. So she's forever in my debt. So now just kind of from here, after doing the LDN and other things, you know, I'm able to do more implementation of like supplements or working out or really whatever it is. I also did Karen DeMarco's coaching program on fibromyalgia. That was helpful. So that's a little of my story. Any questions on that?
How are you today?
Today, I would say 80% better.
Ah, lovely.
Yeah, thank you. I mean, my sister Mary, I don't know if you can comment. It'd be interesting to see your take on it. I've spent a lot of time in bed, and, you know, now after work, I go for a walk, or I definitely do other things.
Charlene, I have a question for you.
Yeah.
How do they arrive at a dose for you? Is it so compounded, and how did you arrive at a dose that works for you?
So I just know my body very intuitively, that I'm very, very sensitive. And so I just, through my reading, the dose of 0.25 milligrams is what I felt like I needed to start at. And a lot of people start right at 4.5 milligrams, but they do usually recommend a titration upwards. So I started at 0.25, and then I would titrate up by 0.25. I did it differently depending. I would do like every couple weeks or every month. And then I would just kind of feel in my body what felt right, honestly, and then would titrate up when I felt like it was time. So if I felt like I was kind of leveling out or inflammation felt like it was creeping back in, I would increase. Or if I felt like sleep, sometimes sleep disturbance is a side effect. If I felt like I wasn't getting, my sleep was very disturbed when I would titrate up, I might back off a little bit. So there are a lot of physicians that will work with you, will work with people to support them in this, this titration. I think that it's a very subtle process. Other people aren't as sensitive as me, and but I think it's nice to find a provider that you could work with that would be open to people titrating, in their own way. That's important. I do believe it's important. Did that answer your question?
Yes, thank you.
Okay. I want to share that a couple things also that I noticed as a side effect were, like I felt like my brain was better organized. I felt like motivation was better for me. I kind of like remnants of like the obsessive compulsive stuff kind of just went away. And my anxiety level, definitely significantly went down. Probably my perfectionist tendencies are still there, but they have also decreased. So that was great. Okay.
Charlene,
Yeah.
did you have any GI symptoms at all? Being as sensitive as you are.
On the medication?
Yeah. Some of my research showed some GI. They said they were rare, so I figured somebody that was very sensitive would probably have experienced them. No?
I did not. If anything, it got better.
Oh, okay, cool.
Yeah, and so the thing is with LDN, everyone is different, and everyone's body kind of seems to react a little bit differently.
Right.
You are working with those opiate receptors, so sometimes some people will have constipation.
Right.
And they're not actually, from what I've researched, 100% sure on why that's actually even happening. But I guess if you had some kind of, kind of thinking out loud here, if you had some kind of underlying pathology going on in your gut, and then your immune system kind of started regulating itself, maybe it's gonna see that pathology and start doing what it's meant to do.
Right.
So sometimes you'll see that, like an increase in symptoms for the first little bit of time, weeks, when you're first starting it, or if you're increasing dose.
Mm-hmm.
People will report that. I personally just kind of kept getting better, which I was happy with. So let's just see here if I've left anything out. I know this is a lot of information. So I just want to talk specifically about this mechanism of action because, as I said, oops, and my computer's dying. Let's not let that happen. 1 second. Okay. Good. So as I said,
Excuse me 1 minute, Charlene, there are a couple of questions that have come up that I'd like to bring to your attention. This is from Rosie Oldham in Phoenix. Have you seen anything that would indicate that this would help other autoimmune issues such as MS? And from Bridget, is there any use in people struggling with benzodependence or withdrawal?
Okay, thank you. So you said the first was from Rosie and the second from?
Bridget Jablonski.
Bridget, okay. So I'll just address the first one, and I will get to the autoimmune conversation in just a bit. Yes, absolutely. There's even been research done in MS and LDN. One of the mechanisms of action that I'll discuss here in a moment is it's LDN's role in reducing central nervous system inflammation, which they're now discovering in conditions like fibromyalgia and MS. So, you know, it's an immunomodulator, and they're really finding this immune system dysfunction at the heart of a lot of chronic illness. And so I like to kind of think of it as like, it's not going to be like, there's no promise that it's going to work for everybody. But if you have almost anything going on with your immune system or inflammation, you know, there's the potential that it could help, I would say. And I will get to, and in terms of autoimmune, people use it for rheumatoid arthritis. People use it for Hashimoto's. Crohn's disease is theorized to be autoimmune, although I have read research where they believe it's actually the body attacking of, you know, a pathogen. But so there's diseases that they anecdotally use it for by translating the information. And then there's diseases that they have actually done research with low-dose naltrexone on. And I'll discuss that research in a bit, which makes me think I should move along here. So LDN, let's just think of two mechanisms of action. Like I said, the first proposed was this blockage of opiate receptors and the that rebound effect of more endorphins that you get. The second mechanism of action that is proposed more by Jared Younger, who is at the, and I'm going to get to the benzo question a little bit later. Let me just highlight that. Jared Younger is at the Neuroinflammation, Pain, and Fatigue Laboratory at University of Alabama. So through his research, he seems more focused on the central nervous system inflammation, which is related to the glial cells, the microglial cells in the brain and the central nervous system. And so what he's more seeing and more focusing on is the blockage of those, of the toll-like receptors 4, which kind of turn off. By blocking that, it downregulates the microglial, so that which if those are overactive in the brain, there can be neuroinflammation. I'm just gonna, let's see, if I have time, I want to show this little video. It's 5 minutes. I'm just gonna show it. I guess if we have to go on, we can in another time. Okay, here we go. See if everyone can see this. So this specifically speaks to neuroinflammation.
Jared is a PhD, Associate Professor of Psychology, Director of the Neuroinflammation, Pain, and Fatigue Lab at UAB. He received his PhD at University of Tennessee. Then he was Arizona State, and then was a postdoctoral research fellow at Stanford. He's recipient of the 2011 Research Award from the American Academy of Pain Medicine. And this morning, he's going to talk about microglial modulation in the treatment of fibromyalgia.
Okay, I'm going to an argument today that in order to successfully treat fibromyalgia, we are going to have to drastically change our approach to the disorder. Fibromyalgia is not about dysregulated dopamine or epinephrine or serotonin. It's not about the overactive nerves or neurons. It's not about any of the things that the current FDA-approved treatments directly target. Fibromyalgia is about neuroinflammation. It's about neuroinflammation in the central nervous system. And the key to treating fibromyalgia is to reduce that inflammatory process in the brain. We're going to have to develop and discover and employ both pharmaceutical treatments and other interventions that can get to the central nervous system and target the cells that drive the inflammation. And I think when we have those treatments, and we'll discuss them today, when we have those, we're going to have an effective treatment for fibromyalgia. But not just fibromyalgia, I think, let me see if I can get this. Not just fibromyalgia. I think when we have these treatments, we're going to have an effective treatment for chronic fatigue syndrome, for irritable bowel syndrome, for Gulf War illness, and a lot of other chronic multi-symptom illnesses. Not just those, but also major depressive disorder. I think we're going to have a treatment for chronic traumatic brain injury. I think we'll have an adjuvant treatment for rheumatoid arthritis when the inflammation has infiltrated the central nervous system and other rheumatologic disorders. And not only those pathological conditions, but I think a lot of the phenomena that we associate with normal aging, like increased fatigability and increased pain sensitivity and decreased cognitive function, I believe a lot of those things are not actually inevitable. I think they're driven by inflammatory processes. So if we can employ these treatments, we can actually prevent or reverse several of these adverse aspects of aging. So the implications of this treatment approach, they're huge. And this field is wide open for exploration. So I'm really excited to be working in this area. Okay, so let me get through some objectives and some caveats, and then we'll dive right into it. The three things we should all know by the time we get done with this talk. One, we should understand the basic states of the microglia and how those different states are very important in terms of our health. The second thing, what are the major treatments we can use to kind of coax these microglia cells into the place we want them to be and to have them take the form we want them to take. And then third, I want you to know kind of the next major research goals, what we're working on next. So I do have some disclosures, no financial disclosures. My money comes from mostly federal sources. I do have some nonprofit institutions that fund my work as well. Okay, I am going to talk about a lot of compounds. I'm going to show you dozens of compounds, in fact. None of these compounds are FDA approved for fibromyalgia. Most of these compounds are not FDA approved for anything. So we're going to be talking about research a little more than clinical practice. And I hope ultimately these things translate to clinical practice, but a lot of these things, in fact, none of these things are mainstream right now. Now, some of these are agents that you could get a hold of right now and you could try. It is possible, depending on how comfortable you are deviating from the mainstream. But if you did that, you would be doing it in an experimental fashion. So that's an overarching caveat throughout the whole talk. Anything I'm talking about, you can be guaranteed it's not FDA. This is my fibromyalgia slide. There's a
Okay. I thought of that. So I think I love that clip because he gives like the whole wheel of other illnesses that could be involved, excuse me, in this consideration of neuroinflammation. And then that piece at the end that he said, you know, this is kind of experimental, but I would add that it's experimental with knowledge. And it's certainly, there's people that are taking this, thousands of people. So, but just know as a nurse advocate, you know, if people, you know, it's not FDA approved for fibromyalgia. So, you know, people might be skeptical or they might have concerns, and that's all, you know, it's okay for people to have that. And so just kind of being aware that that does exist with this medication. So you'll hear about the mechanism of action in regards to the endorphin release of the body that occurs after the naltrexone is taken. Again, back to the theory on the increased endorphins that occur after that coverage occurs, was discovered to be OGF and OGF receptor.
What is OGF?
Opioid growth factor.
Thank you.
And then opioid growth factor receptor. And so let me just excuse me just a moment. And so, you know, the Dr. Zagan that I had discussed before, he's been doing research on this for, I believe, 25 years, over 25 years, maybe 35 years. He believes it's that OGF and OGF receptor that coming together that creates more of a homeostasis in the body, decreasing inflammation. And there's many other things. So So he's at the Penn State Lab, clinical and animal studies. So let's talk a little bit here. We have 12 minutes about, in terms of the benzodiazepine question, that's a great question. I have not personally seen any research on it or even read about it. I would want to know why the person is taking benzodiazepines. And certainly if someone has there might be some central nervous system inflammation, that is a very excitatory state in the body. You know, some people do see anxiety or increase in depression with an inflamed nervous system. So I just want to find out more. I'm not saying it wouldn't help. I just haven't seen any research on it. And you'd probably want to ask some more questions. And of course, work with a provider, because if someone wants to come off benzodiazepines, we know that that should be. So neuroinflammation here, just kind of going back to that, they found the neuroinflammation in brain imaging studies, 31 patients and 27 controls, found that patients had widespread microglial activation using a PET scan. Massachusetts General Hospital also did some imaging, and they also showed patterns of microglial activation in fibromyalgia, but not in controls. We've also measured CSF, but got a link here to a study. Okay, so let's talk about a fibromyalgia study. And Jared Younger is doing a lot of these studies, mainly. And so, let's see here. So 12 weeks on LDN and 4 weeks on placebo. The primary outcome measured by daily assessment of symptoms. And so more than half, 57%, were considered responders per criteria. Patient satisfaction with life and mood were significantly better with taking LDN. Due to no reported side effects in the pilot study, it was interesting that vivid dreams and headaches appear more commonly while taking LDN, even though the treatment was rated tolerable as the placebo. So again, those vivid dreams and headaches are the most reported symptoms, but people, it kind of outweighs it, because if you've been in pain for years and years, and then suddenly you're not, and again, that's not happening in everybody, but if it does, you know, I would think a vivid dream can deal with. So, and it does say here they were minimized once LDN dose was lower to 3 milligrams. So sometimes you need to titrate, that's what I was saying. And it's not always more is better with LDN. Sometimes it's 0.25 milligrams is going to be your ideal dose. So changes in cytokine, which inflammatory cytokines are markers for inflammation in the body. Profile following LDN treatment. It was a 10-week single-blind study that included 8 women in the final data analysis. The first 2 weeks were reserved baseline studies. While LDN was administered during rest of the period without placebo or control group, even though the patients were told they could receive the former at any time. Outcomes have shown a significant decrease in inflammatory cytokine levels, notably IL-6, which is interleukin 6, TNF-A, which is tumor necrosis factor alpha, transforming growth factor, TGF beta, and interleukin 17, interleukin 1, interleukin interferon A. To know what all those are, I'm going to get a degree in immunology. Just kidding. Okay. So, I don't know why this slide, I apologize. So here's some information study in the early 2000s, multi-center pilot, 40 participants, period of 6 months. Drug was well tolerated. Statistically significant decrease in spasticity was noted, and the level of beta endorphins in patients' peripheral blood mononuclear cells increased concurrently with LDN administration. And so,
What does that mean?
what does it mean?
Yes, I'm not sure I understand.
Okay, so what it's showing is kind of that we talked about that rebound effect that occurs when you cover the
Right.
opiate receptors. You have a rebound effect of endorphins. And what they show is endorphins are anti-inflammatory in the body. And in addition to that, they're showing in people with multiple sclerosis and fibromyalgia in other studies that they actually have a lower level of endorphins kind of circulated in their system. So this is by drawing this blood and noting it's just showing that that rebound effect is actually occurring with the administration of the LDN. I would say that's how I interpret it.
Thank you.
Thank you, Karen. Okay. So the next study here, just going to get to the meat of it. 60% of patients reported less fatigue while taking LDN, and only 4 people graded it oppositely. In of life, 17-week-long, 8-week-long randomized placebo trial. There is some that there has been, in research, sometimes they don't show a result. But sometimes, even in the Facebook forum, I'm in a group, some people have no response to this. And so that does happen. The latter had completed the trial, and a significant improvement was noted in mental health components, estimating quality of life. Haley disease. I was not super familiar with that before this. I'm still not, actually, but I believe it's a genetically, it's a skin disease. And so all 3 patients noted significant healing of erosions and plaques starting from peripheral aspect within 1 to 2 weeks of treatment, and clinical resolution of lesions within 2 months. Discontinuation of low-dose naltrexone resulted in flaring of symptoms, which cleared within 2 to 3 days of re-challenge with low-dose naltrexone. That's only 3 patients. Obviously, that's not that many, but I think we can look at some of these smaller, even just anecdotal stories, and just note it's very interesting at the start of the medication, and then you take the medication away and the flares come again, and then reintroduce the medication and now everything clears up. I just find that, very interesting and promising. So Crohn's disease. Honestly, I've been pretty amazed at what I've read about Crohn's disease and LDN. So open label 17 patients, LDN 4.5 milligram, 12 weeks. After the treatment, 89% of the patients were deemed responders with a decrease in CDAI score by 70 points. Well, 67% achieved disease remission. So we have a disease remission happening. How often does that occur? How often do we hear that? And it's a medication with, not that many reported side effects. And it's amazing that there was remission. That to me is just, so quality of life significantly improved. The effects lasting even 4 weeks post LDN, so it must have been discontinued. And again, sleep disturbance was noted in 7 patients, but it was well tolerated. Some more information, and actually there are pictures. I should have put them on here. You can go on and see the endoscopy, the mucosal healing. There's interesting pictures. So really seeing the effect of that mucus healing. I mean, that's, to me, and that's just by prompting the immune system to take care of itself, to re-regulate. So, okay. I'm gonna go back up here. So here's one list of some diseases that could possibly be treated with LDN. You notice on here. I'm just gonna read a few. Autoimmune hepatitis. They do note breast cancer, non-small cell cancer, PCOS. I know of someone that had very good effects with endometriosis, was in significant pain, started LDN, and their pain significantly decreased.
So we could actually on our own go to that if you could flip back, the LDN Research Trust, the patient information packet.
Yes, and I'm gonna bring it up if I hopefully have time here. I guess I just need to move along here.
Yeah,
So-
if we could begin to come up with conclusions, that would be good.
Great, thank you. So psychiatrists are using this. Let's see. This is an interesting study on bone density in mice using LDN, improving their femoral bone mass. People are using CBD and THC together. Let's see. So in summary, I would say more is not always better. I would say if you're interested in using this with your patients, do your own research on it. But this I've included in the back here. I'm happy to send notes or this PowerPoint. The LDN Research Trust.
Yeah, if you will send me the PowerPoint, I will distribute it.
Okay. I mean, there's just so much information out there on this. It was hard for me to.
Oh, it's fascinating. I'm astonished at the range of applications.
Yes.
I mean, bone density, really?
I know. No, I have not seen that anywhere else but that one study. So I can't claim that, but it's just, and that was in mice, but interesting. So this is LDN prescriber information. I would say to probably just download this and read through it. I was going to on the call, but there's a patient one as well. Go on the it's called LDN Research Trust.
So this would be information that we could take to physicians to explain why we're asking about the potential for LDN with a particular patient.
Exactly. And there's a lot of doctors that will not prescribe this. Things you'll hear are like, oh, I don't prescribe narcotics. And it's like, oh, it's not a narcotic. Actually, it's gonna have it's doing the opposite. So there's a lot of misinformation out there, and you just kind of have to deal with that because that's the world out there in regards to this. There's a little bit of a stigma because it's been used as an addiction medication. But what I would do is to print out, and I've attached the links in here. Print out like some of the, like Jared Younger, I like his fibromyalgia studies. Print those out. Probably the MS study, the Crohn's study is pretty amazing. But also just this little summary that someone has already created for you. You could show that it's even at, Stanford has done a paper on it. People like when large organizations are studying things, they tend to respect it a bit more. So here's some things to ponder or things to note. There's a lot of good information out there. If you have someone that wants to try this and they have cancer, I did not discuss that. There's a whole world out there on that. There are some considerations such as people on medication such as like Keytruda. I have seen where they say not to take it, and I'm not sure if that's because of LDNs. I think it potentially increases T cell proliferation, but I'm not 100% on that. So some things to ponder. If you have someone with Hashimoto's, you want to watch them carefully if they're starting LDN, because their thyroid antibodies can go down. And if they're on thyroid medication, you don't want them to go, become hyperthyroid and not being monitored properly. You're not going to want to still be taking your oxycodones and your LDN at the same time because the LDN is blocking the opiate receptors. So if someone's on an opioid medication, you need to work with a doctor on titrating down and how to incorporate LDN. There are some people I have noted that are taking LDN with opiate. They seem to be taking it different times a day, but a lot of people do not do that, and I'm not familiar with how to do so. different dosing is out there. You'll see twice a day dosing. You'll see most people recommend taking LDN at night around 9 p.m. so that the endorphin release of the body is highest between 4 to 6 a.m. So you take it at 9 p.m. and then you have that surge of endorphins overnight. That's the most usual way to take this. Some people, if their dreams are just too vivid, they're changing it to a morning dose. Some people take a twice a day dose and they're noticing, you know, how their body feels with that. An issue for me, I think, is this is kind of a population public health issue. You have to pay out of pocket to get LDN, and I don't think it's okay that there's populations of individuals that do not have access to this medication. So I think that there are people that are advocates out there kind of pushing that point as well. In addition, mostly, you know, to get this medication prescribed, you'll usually have to go to a functional medicine or integrative medicine provider. Although a lot of more mainstream doctors are prescribing this, you know, but a lot of doctors you're paying out of pocket for. Again, that to me is more of an access issue. There's a new study starting for endometriosis at Penn State. A lot of the studies are paid for by donation, or, you know, they're done at colleges or things, but again, there's not a lot of money around this topic. There's a link here to find an LDN qualified doctor. There's an LDN doctor online. I know someone that used her. I'm not sure how she's licensed in all the states, but she is. I can't speak on her, but I know someone that had a good experience. So,
So if I know that you've had to speed through, there's a tremendous amount of information here. You've done a beautiful job. Thank you. If we have more questions, can people, the nurses, write to you? You want to give your email address and in case they have more questions?
Sure. Yeah, absolutely. innerstrengthrnpa@gmail.com is my email. Again, this is a medication with a very low side effect profile.
What is the half-life of LDN?
That's a great question. I know it seems to elevate the endorphins in the body for about 24 hours after it's taken, but I don't know the half-life. I would have to look that up.
Okay.
If you also would want to go to a pharmacy that is familiar with compounding this. Again, there's a list on the LDN Research Trust or ldnscience.org. You want to look out for filler. You want to make sure the filler that they're using is appropriate, meaning it's inert. It's not interacting with the drug at all. Some people have problems with different fillers. Some people don't. So just noting that people who are extra sensitive may have some kind of side effect with fillers. So you want to talk to your pharmacist about this. I would want to know, are they a pharmacist that has experience with LDN? Are they a pharmacist that has compounded this medication before? So Skip's Pharmacy is one of the most famous pharmacies for compounding this. They are kind of one of the pioneers, and they believe they do ship. Any questions?
Well, for myself, I am really looking forward to going over a lot of your resources here and reviewing the slides again. There's a tremendous amount of information, and thank you so very, very much for bringing this to our attention. This is certainly something that every RNPA needs to know.
Yeah, thank you. I know I was speeding through. I tend to be a bit overdone with information, but I do want to point out a book that I'm starting to read. It's called The Inflamed Mind. This is a very interesting book because it's actually a radical new approach to depression. And some people do use LDN for depression. And it has been one study on that, but it was, I think, used with another medication as well, but it showed some positive effects. And I certainly do feel a mood uplifting effect from it. Any,
Just one more question for you. What would be the most appropriate labs to check for neuroinflammation? You mentioned IL-6 and TNF-alpha. Is there anything else?
that is a great question. So the topic of neuroinflammation and even microglial activity is, it's really pioneer medicine. They, in my opinion, you know, for the longest time, they didn't even know that there was immune cells in the brain. And now, oh my goodness, there is, which, like, this information is mind blowing, right? And so the answer partially is I don't know. But I mean, you can look for systemic inflammation markers, you know, C-reactive protein. I would have to get that information for you.
Okay.
I had an MRI that showed it, but some people do a PET scan, or, you know, Amen Clinic does a SPECT scan. There's a lot of debate, from what I can tell, over people's theory on a SPECT scan. But yeah, I don't fully, you know, you can also look in cerebral spinal fluid. But that's a lumbar puncture, and you have to have someone that knows what they're doing and is also looking for different pathogens and things.
Yeah, I won't be signing up for that real soon.
Yes, I actually refuse to have one. So, if you know, if you look at like the PANS and PANDAS research, they do something called the Cunningham panel. That is kind of shows autoimmunity markers in the brain, and that can give an indication of certain inflammation that's occurring. That's out of pocket. I believe that's $895. That is not a diagnostic laboratory test, but it is an indicative. So, you know, kind of goes in the column with more information that could lead you down a different path. But they are, you know, they're finding inflammatory markers even in individuals with schizophrenia. It's just this world is really opening up where we're really seeing the mind-body connection, I feel, a whole different way. So I think it's pretty promising. But I could look that up, that neuroinflammation lab. And
All right. Thank you, Charlene, truly, for a tremendous amount of work putting this together. It's beautiful. And I will be sending it out to everyone, and I will be utilizing it in classes to come. This is really terrific, and thank you very, very much.
oh, you're welcome. There's a lot of information still, so do your research, be safe. You know, even with cancer, they sometimes recommend, it's not, you know, certain people recommend not taking it a week before chemo and not taking it a week after. So I've only covered really basics here. So, you know, I just do encourage people to do their own research. There's a lot of amazing podcasts out there on this. Dan Rubin, even, Karen, I sent you one he did. He's the Fabno. So, you know, there's a lot of information. There's a lot of people that are very passionate about this because they've had such a dramatic result.
Well, I thank you, truly. If there are any other questions, now is the time to speak. If not, we'll let you go.
This is Yvonne. I had one other quick question for Charlene.
Sure.
Do you know what the half-life is? Like, do you have to take it more than one time in a day, or does it vary depending on the individual?
So it's usually, I don't know the exact half-life. I would have to look that up. But I do, it'd probably be very easy to do. But I do know that it's usually just taken one time a day, and it's usually taken around 9 p.m. The goal is to block the opiate receptors between the hours like 4 a.m. Yeah.
The half-life of LDN is 4 to 6 hours.
Okay.
Great, thank you.
Yep, and you want immediate release. You do not want any slow acting because that would negate the benefits that you're getting from the immediate release. And
Thank you very, very much.
I could talk all night,
I
Karen.
know. Thank you very, very much.
You're welcome.
All right, we'll let you go.
Thank you.
Thank you.